Okay, well, welcome to the webinar. Unofficially, we're waiting for a couple of minutes until people to give people some time to call in and to get into the webinar room. We just wait 2 more minutes. Okay, the number of participants, the increase of the number is getting slower, so I think it's time to start for this monthly webinar of the spine section. Welcome to everybody who joined us here for this evening for the spine section webinar. And today we have a special guest talking on an important, very daily business topic. We have Professor Claudius Thomé, who's chairman at the Department of Neurosurgery at the University of Innsbruck. And he's going to talk tonight about the timing in the treatment of lumbar disc herniations, which does sound on first glance easy, but on the other hand, we do know that lumbar disc herniations recover quite well under conservative therapy, and there's still this ongoing discussion what grade of paresis should we operate. But on the other hand, we know the earlier we operate, the better it gets. The outcome gets for those patients, though there's a certain dilemma of how long should we wait for a conservative treatment to step in or to be effective, and how long can we wait until we operate those patients. And this is something Claudius is going to talk about tonight. It's about the timing in the treatment of lumbar disc herniations, as from his department, they recently published some important works on the recovery or on the motor outcome of those lumbar disc patients. So as always, when you have a question, please type in your question in the Q&A box or the chat box, and afterwards in the discussion, we're going to pick up your questions and discuss those questions. Now, Claudius, I'm happy to have you here. Thanks for coming, and it's your stage now. Thanks.
Sure. Florian, thanks for having me. Always great to be involved with the ENS and also in the webinars. As you said, the topic, I'm going to share my screen. The topic is actually at first glance doesn't seem to be too sexy if you think about it, and it seems almost a little too straightforward, and people think they know everything about it. But I would like to cover all the issues on the treatment timing in lumbar disc, something we see all the time, and also talk about motor deficits and the work we have published. So I would like to start with disclosures, which shouldn't really matter for lumbar disc surgery, so I can step right in. And first, I would give you some basics on lumbar discs, which have some influence on indications and timing, talk a little bit about indications for surgery and maybe their respective role in the timing that we need to approach there. Some evidence on surgery for pain, surgery for motor deficits, and there I'll show our own data that we've collected over the last couple of years, and then go to some take-home messages, and I hope to be rather brief so that we will have some time for discussions or questions and answers for everybody in the audience. So basically, we all know that when we talk about disc herniations, most of us would talk about mediolateral or interforaminal, and there are also extraforaminal lesions. And the data out there is either on everything combined, or most of the data is for regular intracanalicular disc herniations. So the extraforaminal usually are not that well covered by evidence if you talk about timing and the recovery of paresis in relation to timing. Something that's also important is I always like to remind you of this paper by Wilco Pohl's group, actually now 10 years ago, that actually found out that without MRI, without imaging, that the individual tests neurologically we do for identifying the disc level is actually quite poor, and you're surprised that this is not as good as you would want it to be. And also importantly for indications of surgery if you look at data from the sports trial on how to diagnose either disc herniation, that's rather simple, and most of the evaluators would actually be pretty good in identifying a morphologic disc problem. But when we talk about compression of the thecal sac or root impingement, then we realize that actually our inter-rater agreement drops quite significantly. And this is a potential problem also for indications for surgery if we don't even agree on whether a nerve root is compressed or not. And this seems to be more of a problem than we would generally think. The therapeutic options obviously are conservative treatment, mostly anti-inflammatories or analgesic medication. We can do injections, and if you look at, again, this data from the sports trial that looked at whether periradicular infiltration with steroids did help, they could at least show that the patients that received an epidural or a PRT, as we say, they would quite often in 42% change to a non-surgical treatment, whereas only 12% without a steroid injection. So there's some value for these to avoid surgery as well. And now to the main topic on disc surgery in general. What do we normally talk about when we see those large lumbar herniated disc? First, we want to know when to operate it, then how. So it's about indications, timing, and potentially the surgical technique. I'm not going to cover surgical technique in a very limited fashion. Indications, I'm going to talk mainly about timing. What about the indications that we have? I would consider, let's say, the 5 or 10 years ago, it would be quite clear that it is non-controversial to do disc surgery in a case of Cauda equina syndrome, in a case of high-grade paresis, which was defined usually as less than 3 or equal to 3 out of 5, and those rare patients with very intense pain refractory to treatment. And the controversial or more controversial indications where you have neurologists, for example, saying, oh, they don't need surgery at all, and us surgeons being more aggressive in going for surgery is radicular pain, refractory to conservative care for, I would say, at least 6 weeks. I'm going to talk about this in a minute. And low-grade paresis, grade 4 out of 5, was quite often not considered an indication for surgery, particularly when you talk to non-surgeons who take care of those patients. First, I would like to cover the controversial pain indication, where still there's a discussion on when and to go for surgery and when to wait and stay conservative. The pain indication, we know from the sports trial that if you randomize for surgery and for conservative care, that many patients cross over. So if they were randomized to the conservative arm in the sports trial, about half of the patients actually ended up going for surgery later on, but also the other way around, 60% randomized for surgery were not operated, showing us that many patients actually, while waiting for surgery, will recover and will in the end not need surgery. So this is something important that we have to know about. And the very, very important studies by Wilco Pearl, published now quite some years ago, comparing in a randomized fashion early surgery, meaning within the first weeks, and compared to conservative care, we found out that actually the result is the same after a year, but the surgical patients recover much faster. But it also shows that in the conservative group, if you look at both of those red curves, you see that many patients actually recover within the first 12 weeks. And this is also what we see in our everyday clinical practice. Same results, a little different study, and that's why they concluded that you should not operate a patient with a lumbar disc herniation and pain within the first 6 to 12 weeks, because if you do that very early, you actually take the patient the chance to recover spontaneously. But how long can you wait? And there's probably the best data out there, again, from the sports trial, from the States. And they compared patients that were operated within the first 6 months and thereafter. And it clearly showed that if you operate patients after 6 months of symptom duration, they do worse. And this is also what we see in everyday life. Patients that start to have chronic pain, they are out of their job for quite some time, they have psychosocial issues, they have sick leave, and patients that have been on sick leave for 6 months have a much lower likelihood to get back to their regular life and work. Surgery is cost effective. That has also been shown in some studies. You don't have to look at the details and the exact data here, but it's quite obvious that if you treat patients, that quick recovery actually is cost effective, even though after 1 or 2 years, outcome will be the same at the end. And also what is important more for indications, not necessarily for timing, but also has an implication for timing, is that there are many factors influencing outcome. Here are just 2 papers showing workers' compensation or obesity as influencing the effectiveness of surgery. And of course, if you have a patient that has psychosocial issues and workers' compensation issues, you would not want to treat them after 6 weeks. You may want to go a little longer for conservative care, potentially. So in summary, for pain, for radicular pain, for radiculopathy, if you compare surgery versus conservative care, there are a number of RCTs out there, and all of them basically showed if you do surgery, they are better early and they recover faster. But basically all patients or most patients also recover with conservative care, but that happens after a year or even a bit later. And if you have pain for more than 6 months, outcome is worse because there are some chronic disability and chronic pain issues there. So ideally, you could summarize that for pain, radiculopathy, surgery with no motor deficit is indicated after at least 6 weeks of conservative care and should still be performed within the first 6 months. So in between 6 weeks and 6 months, that's when you should go for surgery. And obviously there are different patient parameters that influence the usefulness and the efficacy of surgery. Now, if there are many studies out there showing some other aspects of this. To be honest, we here in Austria, we are always confronted with waiting list issues and patients having to wait for 6 weeks or even longer, 8 weeks for a lumbar disc operation. And this is considered quite dramatic for the patients. And if you look into Germany or Switzerland, patients don't need to wait long for their lumbar disc surgery because there are plenty of surgeons out there. So it depends on the surgeon's density in a country, obviously how long you have to wait. And to be honest, I think waiting lists are great because many of those patients will recover spontaneously and won't need surgery. And if you would ask yourself, would you go for surgery within the first couple of weeks if you would have a lumbar disc without a deficit? Probably none of us would go for surgery. So waiting lists, to be honest, I think are a great thing. That's why I put that in green. And if you talk about private insurance, there are also good studies out there. If patients are privately insured, they have a likelihood of 3 or 5 times higher rates of surgery, which tells us that obviously we are not unbiased, and access to healthcare throughout Europe, but also in the United States, depends on your insurance level, and you will go for quicker surgery if you are privately insured. So this speaks for waiting, to be honest, probably 12 weeks to go for surgery in a regular lumbar disc. And the other counterpoint that you still have to mention is the employment, that obviously if you are out of your job in nowadays difficult situation, depending on the country and the social system you have, if you're out of your job for 3 months because of that, this may be a problem. So this may indicate going for surgery earlier to be able to stay employed and not have such a long sick leave there. So this is surgery for pain. Now I'm going to talk about the non-controversial part, and also the low-grade paresis. And this is basically the data we gathered over the recent years. And I'm always surprised that still many surgeons and, of course, neurologists, etc., say that for a grade 4 to 5, even quadriceps weakness, you don't need to do anything. So we looked at these acute surgeries for lumbar disc herniations. Of course, if you have massive uncontrollable pain, that's an indication. Cauda-Equina syndrome, I don't think anybody argues that this is something that shouldn't be treated immediately. And if you look at the data out there, there's more data, but these are the most important papers out there suggesting that Cauda-Equina syndrome should be operated within 48 hours. 24 seems a bit too short, or of course, if you see the patient immediately, you would go for surgery immediately. But later than 48 hours, outcome becomes worse. And it's quite clear that if you operate after 48 hours in a true and rather complete Cauda-Equina syndrome, only very few recover, which is a nightmare for those usually young and active patients because they are incontinent, they have sexual issues that are problematic. So this is a true emergency, and I think nobody in Europe disagrees that this should be done even at night. Acute motor deficit is much more of a discussion, and it's much more of a discussion whether those patients should be handled as an emergency or not. And it already starts with the radiologists. Do the patients need an MRI right away? Can you do the MRI the next day, 3 days later, outpatient, and the patient comes back with the MRI? And of course, do you need to go for surgery, maybe on call, maybe in the regular program the next day, maybe next week? And these are questions that are sometimes difficult to answer, because if you see the patient in the emergency room or in your outpatient clinic, you will have problems with your radiologists saying, oh, I don't have time for an MRI. And even worse, with anesthesia, if you tell them, oh, I need to do this case tonight or on the weekend or whatever. So these have been discussions in the past, and that's why we looked into this quite severely. And if you see the literature on this, there are some statements by the Dutch that saying that, well, most spine surgeons would go for early surgery in case of high-grade paresis. This seems logical, and I think all of us would try to do that. But if you look at the 3 prospective studies that were published many years ago, mostly they were treated late, and they found no advantage of early surgery, but they were treated, all of them were treated after weeks anyway. So there was no acute surgery anyway. And also recovery of muscle strength after microischectomy. This is actually 10 years old study, so not that old. And they found that only the severity of the paresis was predicting whether the paresis recovered or not. And the preoperative duration of the paresis did not influence the rate of full recovery, which would tell us, oh, it doesn't matter when you operate the patient. But if you look at the days, how long those patients were waiting for surgery, on average, they were waiting 30 days. And 30 days, obviously, then probably it really doesn't matter whether you do it or not. I mean, when we talk about acute surgery, we talk about days or even 48, 72 hours. Another study looking at foot drops, and I don't want to go in too many details and bore you with too much detailed information on this, but they also found only a mild effect of the symptom duration on the recovery, but patients were waiting for 86 or 204 days on average for their, in this case, fusion surgery. So this doesn't help us at all. And they had a very low recovery rate of 20%, and they recovered only if they were treated in the first 3 months. And this led us to look into our own data. And there was, I would like to show you one more study, again, from Wilco Pearl's group on the recovery. They looked at their randomized controlled trial and whether the grade 4s, because they excluded the high-grade paresis, whether it made a difference, whether they were allocated to the early or late surgery. But again, average treatment was after 9 weeks. So this doesn't help us again in answering the question whether a grade 3 or grade 4 out of 5 should be operated right away, because for them, then it did not make a difference after 9 weeks. And so we looked at our patients first retrospectively, and analyzed all patients that were admitted acutely, not electively, not scheduled. They had a radicular motor deficit, at least 4 out of 5. They did go on for surgery, and we had a follow-up of at least 3 months. That was the first study we published on this. We gathered 330 patients in 3 years that were treated acutely and dichotomized them in surgery within 48 hours and after 48 hours. So the first group was operated on average on basically right after a day, and the others were operated after about a week of showing their deficit. And this depended not on the patient only, but also dependent on anesthesia, on our caseload, et cetera, and obviously, most importantly, whether the patient presented to us on day 1 or obviously on day 10, and which we couldn't influence ourselves, obviously. And these were the results. On the left side, you see the 3 bars with the patients that were treated within 48 hours with a mild, moderate, and severe deficit, mild being 4 out of 5, moderate 3 out of 5, and severe 2 or less. And you see all of those patients recovered. If you go for those patients treated later, so on average 8 days after the onset of the paresis, you see the mild patients recover quite well, moderate less, and severe even worse. So there is obviously an importance in timing there. If you look at this, and you will have 1/4 of the patients not recovering if you treat them after 48 hours. And again, if you look at the statistics of this, the most important part was the duration of the motor deficit in predicting outcome in this retrospective study. So obviously, this is a very important factor. Then people argued, well, when you do that, you can't only look for 3 months. You have to wait longer, because those patients that were treated later will recover later. But at the end, the outcome will be the same. So Niklaus Kögel, one of my coworkers here, took a lot of effort in having those patients back in the hospital after at least 3 years, on average 5 years. So there will be no more recovery after 5 years, I'm sure. And he really did very well getting all those patients back. And then we grouped the patients into 3 groups, treated within 2 days, 2 to 7 days, or after 7 days. And the outcome, I'll show you here again. This is for severe deficit, grade 0, 1, or 2. Surgery within 48 hours on the left, within a week in the middle, and after a week on the right. And if you look at the numbers here, early treatment, basically all patients with severe deficit recovered fully. In the midterm, they did so-so, and if they were treated after a week, not a single one recovered. If you look for a moderate deficit, it's almost, it's comparable. Perfect recovery with early surgery, no recovery with late surgery, and intermediate in between. Obviously, highly statistically significant. Mild deficit was obviously much better. In a mild deficit, it didn't make a difference whether the patient was operated within 48 hours or a week. And even if they were operated late, most of them recovered. And again, the same number of about 1/4 not recovering if they were treated after a week. Sensory deficit is not that important to us, but basically shows the same. If you treat the patients early, the sensory deficit recovers a little better, but after surgery after a week will also only have an incomplete recovery. Then the argument was, or some criticism on our work was that it's a retrospective study. So we followed this up with a prospective trial with 120 patients that were treated acutely, and 60 patients had a motor deficit, and 6 patients actually had a cardiac Quiner syndrome. And we looked at a time interval of 3 days in this series. Just as a reminder, 6 patients with cardiac equina syndrome. Those patients that were treated within 24 hours all recovered. And there were 2 that presented after 48 hours. Both of them did not recover. So this small numbers, but still confirms the results that were seen in the literature on cardiac equina syndrome. Now, the outcome here again was the same. If you have a moderate or severe deficit, patients treated early recover very well. Patients operated late improve, but don't recover fully. Not a single one recovered fully with a moderate and severe deficit treated after 3 days. And for mild deficits, even if they operated somewhat late, I mean, after 3 days is already quite early, but many actually recover even then. So this shows you that there's obviously a difference depending on the severity of the deficit. Now we went to some statistical experts actually from Canada and did a collaboration work with them and looked at all those 390 patients that I presented to you now and combined them and looked at cutoff values and the importance of parameters on outcome. And here on the right side, you see these patients up here. This is preoperative muscle strength, high-grade paresis, mild paresis, and postoperative muscle strength. And these patients were treated within 48 hours, and you see all of them recover well. Those patients that were treated within a week, they recover okay, depending on the severity of the paresis, but still significant number of them will not recover. And those treated after a week recover even worse. And if you look at this, how we analyzed this, we looked at the slope of recovery for each individual patient and used this as the parameter to analyze it statistically. And we used an unbiased recursive partitioning approach, which is like a tree-based model where the algorithm looks at the data and by itself, without you telling the algorithm what to do, looks at what are the important parameters for outcome. And the result was that actually the most important parameter was preoperative muscle strength. And then it was already the timing of surgery. And if you look at this in a different way, if you had paresis of less than 2 days, those patients recovered well. If not, they recovered they recovered poorly within those 3 days. And this shows it a little more illustrative to say. So on the left side, these patients were treated within 3 days. Mild deficit, moderate deficit, and severe deficit. And those patients, basically all of them recovered quite okay. If you treated them after 3 days, patients with severe deficit did not recover. They did very poorly. Moderate deficit did so-so. And even with a mild deficit, a grade 4 out of 5, again, the same numbers, 25% did not recover. So we would conclude from this, if you have a moderate or severe deficit, meaning grade 3 or less, patients should be operated within 72 hours. Of course, if you just have a grade toe extensor weakness, which is probably irrelevant, this doesn't count. But for any relevant paresis, we now try to treat them within 72 hours. And again, for the mild paresis, we looked at the cutoff values that the system came up with statistically. And it's clearly to show that if you treated those patients within 8 days, which is a week, obviously, patients recovered very well. If you treated them later, a significant proportion did not recover and stayed at a grade 4 out of 5. So for a mild deficit, if it is somewhat disabling, and even a foot drop grade 4 out of 5 can be disabling for a young athletic person, we try to operate them now within 8 days. And this was published in neurosurgery. And what I would like to pay attention to, not too much of details, I basically showed you this, but what is important, that the number needed to treat in our study was 2, which is better than for stroke, for anything you have out there in medicine. There's an unbelievably effective treatment with a number needed to treat of less than 2. So in summary, and I tried to be quick on the data we have here, so we have some time to discuss maybe even complex patients or difficult situations. Although early surgery is advocated normally in patients with significant motor deficit, both in the cervical spine and lumbar spine, so far there has been no evidence for acute emergency surgery, or not even a specific time interval, except for the 48 hours that we all believe in for cardiac Quiner syndrome. I didn't talk about cervical disc herniations, but I'm happy to cover this if you have time in the discussion, because we also looked at our acutely treated cervical discs, how they recovered in relation to the lumbar spine. Motor deficits, they fully recover if you decompress them within 72 hours. Even if it's a grade 0 out of 5, if you treat them early, they will do very well. And that's why we now believe severe and moderate paresis warrants immediate decompression. If you have mild paresis, we now actually believe it should be treated within 8 days, because if you don't treat it within 8 days, 1/4 of them will stay with their deficit, and only, which is not that bad, but only 75% will recover. Obviously, this is only applying to patients where the paresis really is disabling the patient. If it's irrelevant clinically, of course, then you don't have to go for early surgery. And for us now, this has changed how we treat those patients, and also changed our way of approaching the anesthesiologists on the weekend or in the afternoon or in the evening, because we know what a difference it makes whether the patient is treated before the weekend or after, particularly with those severe or moderate paresis. So I thank you very much for your attention. And I tried, as I said, to be rather quick within half an hour, so we can discuss the questions that you come up with. Thank you very much for your attention, and thanks for being with the ENS here.
Thank you very much, Claudius. Very nice and very, very important presentation. And for all participants, as already said in the beginning, we're happy to take your questions in the Q&A box. Whenever you have a question, type it in, and then we'll discuss this question. Now, I'd like to start with my question. You showed in all of your studies, whether it was the first retrospective, the then longer follow-up retrospective, and the prospective, that even the mild paresis do better if you treat them before 72 hours. And if you treat them later than 72 hours, you have something like a 70-30 proportion, or 60-40, and the latest one, 25-75%, 75% full recovery, 25% not full recovery. But now in your conclusion, you said you would treat them somewhere within 8 days. But based on this data, you should be even earlier with the mild paresis, within 72 hours to get the ideal recovery for all patients, as this would mean when you're within the 8 days, you lose 25% of the patients.
You're partly right. At least. No. I mean, I know. Obviously, we looked into data very, very, very precisely. And since we first had these cutoff values for 3 days and whatever, then you're mixing the groups somewhat, because and the statistical analysis that we've done with the colleagues in Vancouver, to be really completely unbiased, and that's why we sent it out, not to have any bias on our side. And if they looked at this and analyzed this with their URP statistics, they found that for the mild paresis, for the grade 4 out of 5, actually it's this 7 or 8 days. If you operate it within 8 days, you will have a 95% full recovery. And it's not 100 within 3 days, it's 100. But the cutoff value statistically, to make sense, is actually after 8 days.
Okay, good. Now we have some question in the Q&A box. What do you tell the patient with lumbar disc herniation with 4 out of 5 strengths? who you see in your outpatient clinics based on your study results, would you always advise early surgery in future so that those patients recover quicker? This is what you just entered.
Yes, the problem is most patients with a grade 4 out of 5 don't come to us within the first week. It may be the patient with a quadriceps paresis because he can't walk anymore. With a grade 4 out of 5 quad paresis, you are actually disabled. You are limping badly. And those patients may come, but usually a foot drop grade 4 out of 5 doesn't even come to see us. But if they come to see us within the first week, we tell them, if we operate you now, you will have a 95, 100% recovery. If we don't operate you now, you still have a 75% chance of recovery. And we advise for early surgery. And then some patients, also depending on how disabled they feel, they will go for surgery here in Innsbruck. We have a lot of very athletic people that go on the mountain, and they actually tend to go for early surgery. Most of them do, because they don't want to have a 25% risk of staying with a grade 4 out of 5.
I think that's a very important difference. It makes it a very important point that it makes a difference whether it's somebody who's young, athletic, who's maybe a race cyclist, road race cyclist who needs every little strength in his foot extension, than in comparison to an older patient who does not rely on every full muscle strength he can get potentially back. Now that there's a question about pain. Does it make a difference for the pain whether you go for earlier or later? Is the pain recovery better in earlier surgery than later surgery?
We didn't look at this in too much detail, but pain was not a problem. Pain recovered very well even with late surgery. And probably only if you're really late if patients have almost already chronic pain for whatever, but those patients were not included in our trial, then it would make a difference. But we don't care about pain, to be honest.
Okay. Now a good question. Do you still operate a severe paresis in a patient which has no more pain? This is a very difficult point, because you think, okay, maybe the pressure on the root is gone, and this is in the process of recovering. But then you experience some patients who have no more pain and have still this ongoing paresis. How long would you wait?
That is the most difficult question. And to be honest, whenever I give that talk or present our data, that's the question that comes up. And I don't have a good answer from our data. Because we only included patients that were operated, and most of those patients came rather acutely and still had pain. Again, what we do right now, we don't worry much about pain. If a patient comes in with a severe deficit and he comes in rather early meaning probably within the first 2 weeks, we always go for surgery, even if he's without pain. Because we think there's a good chance of some recovery. If the patient has been with a paresis for 6 weeks, 8 weeks, then we discuss it with them. And to be honest, I'm not sure it will help much then. Even if they have had, let's say they had pain for 4 weeks, and then they had the foot drop for another 4 weeks, and then they come to see us, 4 weeks, no pain, probably surgery doesn't matter much. But after our data, we are more aggressive now. We tend to do more surgery even in those patients.
Okay, we got some questions for surgical technique. Does the technique vary depending on the timing of surgery?
No.
When you operate?
It's only, you have to decompress the nerve root, whether you do it even macroscopically, microscopically, or endoscopically, doesn't make any difference. Nothing is better or worse.
Can you comment on sequestrectomy versus discectomy plus discectomy?
Well, we probably in 90% of our patients, we perform sequestrectomy. We would only perform a discectomy, microdiscectomy nowadays, or nucleotomy nowadays in patients that have a real big hole in the annulus and have a very high disc. Other than that, we only take the fragment in the vast majority of patients.
Okay. Did you include any patients who needed fusion in your study?
No.
Okay. Now we got some recovery question. When do you allow patients to start with sports after discectomy? how early is it? But is there? I think there's no real data on this, or
The data on this is rather poor. What we do, I tell my patients to not do active sports for 4 weeks, but they can walk, they can even hike the mountains like the people do. I don't care about that. But real sports, I would say, not within the first 4 weeks. After 4 weeks, they're allowed to cycle, run. But any sports, I don't know whether it's true. That's just my gut feeling. Any sports that's related to a lot of rotation movement, tennis, stuff like that, or heavy loads like skiing. Skiing actually can give you heavy loads on your spine. This is something I don't let them do for 2 months.
Golf.
Golf.
Common
question. I usually tell them you should not do it for the first 2 months, but this is not evidence-based.
Yeah, just gut feeling.
Yes.
Okay, does a sequestrated disc herniation with power deficit make a difference with the contained disc herniation?
Not for our data, no.
Okay, and then some. Very good. What can we do as clinicians to make patients come in earlier? And thank you for your presentation.
Well, the problem is, I think the first step now, because we were surprised how strong our data is. We thought it would be much more heterogeneous, and it would be much more patient factors being involved, and it's really only timing and severity of paresis. And I think the first step is that us spine neurosurgeons have to be aware of that. We have to discuss it with anesthesia, neurology, and our colleagues. And then the next step, hopefully, would be to then go to the GPs and tell them. And we are now doing we are putting that data together for the Deutsche Ärzteblatt, for example, so that this is something that they already agreed to publish this. So this is something where we want to try to actually get it out to the GPs, and you can start doing that in your local community. And now our paper, I think, should be enough proof to at least go into that direction. And hopefully others will also look at their data and maybe confirm what we've found. But I'm very sure that this is quite reliable data.
Now, you mentioned for pain, you would go for surgery somewhere at time point 6 weeks or maybe also 12 weeks. But what does it mean for a younger patient who has a work leave for 6 weeks, 8 weeks, 10 weeks? And why not go for earlier surgery? I mean, complication rates of lumbar disc surgery and down the road complication is so low. Why should we wait in those patients for weeks and weeks of ongoing pain before we take the threshold for this very small, very low complication rate procedure?
No, Florian, you're of course right. And I was brought up in Germany, as many know, and there, if you are at a big university hospital and you have a disc patient, you say, "Oh, perfect, because you don't have that many anymore. Let's get him to surgery." And it's even worse in the private sector, because they treat them, "Oh, come tomorrow. We'll do it tomorrow." And I thought this was a very good way of doing it, and the patients would do quite well. Now here, we have a waiting list of 6 to 8 weeks, and I see that the patients overall, I think, probably do better. So on average, they're probably operated after 12 weeks. Quite a number of them don't need surgery anymore. So they do well without. So for me, I don't care whether they do it within 6 weeks or 12 weeks, whether they do it after 6 or 8 or 10 or 12. I don't think it makes a difference. And I agree with you. If you have a patient being employed and he has been in pain for 6 weeks, then we go for surgery. And to be honest, like probably all of us, if the patient is in severe pain after 6 weeks or significant pain after 6 weeks, then I don't tell them, "Oh, wait for another 6 weeks." But many patients already are somewhat better after 6 weeks. They are not as bad anymore. And then I think it would be wrong to do surgery on them. And many of us do it for not the right reasons. At least I would argue that this is a case if you look at the data from private insurance versus public insurance all over Europe, to be honest.
Yeah, that's certainly a problem. So can you comment on recurrent disc herniations? What the risk factors and how often do you see recurrent disc herniations and in what type of patients, and how we could potentially prevent recurrent disc herniations?
Yeah, I mean, as some of you know, obviously I put a lot of work in device, or worked a lot with devices, clothing the annulus and doing just sequestrectomy. I think the most important part now for me is, if I have a fragment and the annulus is closed, or I have a minimal annular opening that I maybe can palpate, but it's not even a hole really, then I just do a fragmentectomy. I don't touch the disc, because I think if you touch the disc, if you go in there with your rongeur or even cut the annulus open, you will create the door for recurrent herniation. So I'm very reluctant to do that nowadays. If I have a high disc and a big hole, I still go for a microdiscectomy, since we don't have anything now to plug the hole at this point in time, to avoid a recurrent herniation. If the question was also with regards to whether how is the paresis and recurrent disc herniations, we do not have high enough numbers, but it looks like it's probably pretty much the same if you talk about timing.
Okay, well, once again, a question from my side concerning conservative versus surgical therapy. If you compare conservative to a pure sequestrectomy or fragment removal, what does it mean for the disc? Is the conservative therapy still something which has an advantage for the overall degeneration of this disc? Is there an option for the disc to fully recover to a disc with no degenerative signs? And is surgical always worse in comparison to this? Is there any systematic data on this?
There's no systematic data on this. The good data we have on fragmentectomy only versus microdiscectomy is actually from our study that we did years ago. And there we found that if you just do a sequestrectomy, actually your degeneration of the disc will be minimal.
But this is going in the disc space versus only taking the fragment.
Exactly. And if you go in the disc space, you will accelerate the degeneration. And this is also what we found with the annular closure devices, that if you do something in disc, degeneration will accelerate. And there's no data on this, but I would expect that, as you say, disc surgery, or wrong, fragmentectomy will not be worse for the disc than conservative care, because you're not doing anything in the disc, and I don't think it makes a difference. So you're right, surgery doesn't harm in that regard. At least there's no indication that it does.
Okay. One more question on timing. What do you tell your patients when they ask how long will it take before the paresis has recovered? What do you tell a severe, mild, moderate versus severe?
Well, that's a very difficult question. We used to always say it takes at least twice as long as the paresis was there. That was in the good old times. This was our rule of thumb. Now, actually, with the data we have, even though this is variable, and we looked at the patients after 6 weeks and 3 months, we now know that those patients recover usually within the first 3 months. And there's no late recovery, as some suggested. Either they don't recover within days usually, unless those treated within those 72 hours, they recover quite fast. And only those, if they have a very severe deficit, it takes them longer. But usually we say it takes them around 6 weeks as a rule of thumb, but even for those high-grade patients.
Okay. For conservative therapy, do you do periradicular injections, epidural injections, and what do you use? Steroids, local anesthetics only, and do you use oral steroids? As this is, I experienced this a lot, that when people go to people in private practice, they all get on oral steroids.
Yeah,
it seems to work, but the literature data on the other hand shows there's no real benefit.
Yeah, well, this is always also discussion in our group, because some say, oh, oral steroids may not be that a bad idea, and some people outside, some of the neurosurgeons outside would potentially think about doing that. And as you say, many practitioners do that. I never use oral steroids. I use anti-inflammatories. If I think conservative care makes sense, which I do, as I told you, quite often in just pain. And I would go for those patients, I would go for a periradicular infiltration with local anesthetic and steroid. And also depending on the case, but in some of those acute patients, this does make sense and gives them some relief. But I'm not somebody who's doing that too often. Some people do that for everybody. I don't. I do it on, I try to pick those patients where I expect this to help a lot. And I don't, as I said, I don't use oral steroids. I'm not saying it's wrong, but as you say, the evidence is quite low. And I think for me, it doesn't make any sense to give something that has quite a lot of adverse effects.
Okay, we have a question for instability. Well, that does make is an argument for the timing of surgery. Usually it's not that much of an issue in this condition.
No, the only patients we see there, which is actually, we see a few patients, maybe 5 a year, with a spondylolisthesis, a lytic spondylolisthesis, and they present actually with acute hernia into the foramen, with the L5 foot drop, with an L5S1 spondylolisthesis. And then we would argue we would go for acute surgery and probably fuse that patient if he has an instability because of that. But this is rare, but still the timing would not differ.
Okay. And now finally, with the question we get a lot from our patients. What about yourself? If you have a sequester with a grade 4 power deficit and tolerable pain, would you go for early surgery?
Now with our data, if it would be a debilitating, if I would feel it when walking, I would go for surgery, absolutely.
Yeah.
The difficulty, and maybe now I'm criticizing our own study, is that a grade 4 paresis is somewhat a spectrum of deficit. And a grade 3 is quite clear, that's already pretty bad, but a grade 4 can be a mild grade 4, and it can be a more severe grade 4. And this may also influence the decision, but in our study, obviously, we just grouped it as objectively into those MRC grades.
Okay. We do have a question for endoscopic surgery. Do you use endoscopy? Would be my question. And is it how would you judge endoscopy for lumbar disc herniation? Well, what's your opinion about endoscopy?
Yeah. Well, we have started now to do transforaminal endoscopy 2 years ago, 3 years ago, and we are slowly picking that up. Mainly also because I think transforaminally it has a role to be less invasive. I personally, even though people say it works great, I don't see a big advantage of doing an interlaminar endoscopic procedure and then having a 8mm working channel rather than a 14mm tube, and you do a tubular intercanalicula decompression. I don't think that makes a difference, to be honest. And endoscopy for me is more difficult, but we do transforaminal endoscopy, and in our hands it works well, but we choose patients still quite carefully, I would say, and only use those that we think work very well endoscopically, and that has worked well. Actually, the patients, the surgeries is less invasive, there's no doubt. They're up and walking basically a couple of hours later and don't have much. We don't have data on recurrence rates yet. In the literature, it's quite clear that recurrence rates are a little higher. It depends also on the type of endoscopic technique you use. Because if you use the technique where you go in the disc first and take a little part of the annulus first, because this is your safe anchor in Camden's triangle, for example, and then you go more into the canal to take out the disc, then actually I'm worried that you will increase reherniation rates. And this for me is a more invasive procedure because you're actually destroying the annulus potentially. And you do this on purpose, but this depends on the endoscopic technique.
Okay. How would you manage a L5-S1 foraminal or recessive disc herniation? Let's say foraminal disc herniation.
Well, like all of us, very individually. I mean, it really depends on the case. If I feel like I can get it through a translaminar approach, I go for a small translaminar window and take it out through the lamina of L5. If it's more extraforaminally or if I think I can reach it from the outside, I would actually do an extraforaminal approach. What we've done now sometimes, we have actually done a contralateral approach, coming from the other side, and tried that a few times, going over the top without decompressing ipsilaterally, of course, over the top into the contralateral foramen and grab the fragment there. But those, to be honest, I'm not that worried about those fragments. The fragments you can get out okay without destroying the joint too much. For me, the problematic cases are those foraminal protrusions that you can't really grab, and to decompress those, that is very challenging, at least in my hands.
Okay, Claudius, thank you very much. I think there were many questions. This shows how important this topic is. And as we said in the beginning, it seemed at first glance you'd think that that's easy, it's everyday practice, but it is everyday practice, and it's a very important topic, and very important to talk about the details. Thanks for the very nice presentation. Thanks for the extensive discussion of this. I think you made a lot of very important points. It was good having you here. So thank you for all participants, for all your questions and your input. Your participating in this discussion was very valuable. We're coming back with the next webinar on the first Wednesday in March. No, we have March in April. I don't know the exact date, but you will be informed via the ENS again, and we hopefully get a very nice presenter for you again. Thanks a lot. Enjoy your evening. Thank you, Claudius, again. Bye-bye.
Thanks, Florian. Have a great evening. Bye-bye.